Good evening, everyone, and welcome to tonight's webinar. We are excited to welcome Dr. Dawn Nixdorf, a dental professional and orofacial pain expert from the University of Minnesota School of Dentistry, and Dr. Payal Sawhney, a neurologist from the Cleveland Clinic. Tonight, Dr. Nixdorf and Dr. Sawhney will present an informational webinar on why it is important for their specialties to collaborate when it comes to diagnosing and treating people living with neuropathic facial pain. During their presentation, they will help you identify key characteristics associated with orofacial pain conditions, how to distinguish trigeminal neuralgia, the most common form of neuropathic pain, from other common pain conditions, and understand when to refer to specialists for further care. Before I introduce Dr. Nixdorf and Dr. Sawhney, I'd like to cover a few housekeeping items. First, there is a Q&A button in the toolbar at the bottom of your screen. Please use that to submit questions. There will be time to answer those after the presentation. Also, there is a free CE credit available for this session. We'll provide the code you'll need verbally and in the chat after the presentation. In order for you to get your CE at the end of the course, you will need to go to cezoom.com. Log in, scroll down until you see scheduled courses in your account. Click the green Verify button for this course, enter the verification code given, and take the mandatory course evaluation and any tests. And for those of you who are not already CE Zoom members, you will need to create a free CE Zoom account to get your CE. There, you can download your certificate or decide to keep your CE stored digitally inside the CE Zoom platform. Now, let's get to our presenters. Dr. Nixdorf is a professor and director of the Division of TMD and Orofacial Pain. His clinical and teaching interests include the diagnosis and management of chronic TMD pain, headaches, and neuropathic pain. His research is focused on the topic of persistent non-odontogenic tooth pain, looking at issues related to classification, diagnosis, epidemiology, exploration of mechanisms, and treatment options. Dr. Sawhney is a staff physician in the Department of Neurology, Center for Neurologic Restoration, Headache, and Facial Pain section at Cleveland Clinic. She is the medical director of the Trigeminal Neuralgia Service Line and is board certified in neurology and headache medicine. Dr. Sawhney specializes in caring for patients with headache and facial pain disorders. She also performs procedures, including onabotulinum toxin injections and nerve blocks to treat certain pain conditions. Dr. Sawhney is passionate about improving the quality of life of patients suffering with chronic pain conditions through medication management and lifestyle modification. Her clinical interests include trigeminal neuralgia and other cranial neuralgias, migraine, and concussion. She is also a member of the American Headache Society and the American Academy of Neurology. She also serves as Associate Program Director for the Neurology Residency Program at Cleveland Clinic. Welcome, Dr. Nixdorf and Dr. Sawhney. Please go ahead.
Thank you.
Thank you. So thank you for that introduction, Brandy. So let me just make sure I can move these slides forward. So we don't have any relevant financial disclosures, and these are the disclaimers for the talk today. So we'll go ahead and jump right into it. I'll hand it over to Dawn.
Thank you. And so I wanted to just briefly go through what is facial pain. Facial pain is pain that is in the face, and we define the face as being from the eyes down and from the front of the face back to about the ears. As you can see in the diagram here, it's this area that is outlined in yellow. And when you're thinking of facial pain, we want to think about it in two broad ways. One is inflammation or disease that is causing the symptom of pain. And things like this are what most of us think about when we think about pain in this area. And that can be like dental infections, sinus disease, and that's inflammation in this area that then gives us that symptom. The other side to it is when the system itself is dysfunctional, and so those would be dysfunction of the somatosensory system, and that could be TMDs, that could be headache disorders, or neuropathic pain like trigeminal neuralgia. And the difficult part is it involves the nerves of the face that go through all these different structures that does not respect how we as society have separated the different parts of the face by discipline.
So that kind of jumps into this next slide that talks a little bit about why facial pain is so difficult to diagnose. And it really boils down to the fact that there's so many different stakeholders. There's neurologists, ophthalmologists, ENT specialists, dentists, neurosurgeons, and pain management specialists that are all involved in evaluating facial pain. So you can imagine when a patient goes to, say, their primary care doctor or their family doctor with this complaint, there's multiple different avenues that they can be sent to. And depending on what ultimately ends up being the diagnosis, sometimes it can take them multiple steps to get to the right specialist or subspecialist to really evaluate and manage their pain appropriately. Additionally, we find that there is variable training in the evaluation of facial pain. So I'm a headache specialist and I have a particular interest in trigeminal neuralgia. So I've done a fellowship and special training to kind of learn how to evaluate these patients. But even, neurologists, when we go through a neurology residency, the amount of training that you have in facial pain or headache disorders can really vary. And if that is not your subspecialty, you may not feel comfortable diagnosing and evaluating these conditions. Finally, we see that a lot of these patients tend to have a lot of different comorbidities that can kind of cloud the picture. So fibromyalgia, other primary headache disorders, TMJ dysfunction can all kind of cloud the picture when it comes to what is actually causing their facial pain. So that is often why we see that there is a delay in diagnosis for these patients. So overall, looking at facial pain in general, when we think about the demographic of your typical patient population, the population prevalence of facial pain is around 2%. There tends to be a higher prevalence in women compared to men. And some risk factors include low socioeconomic status, smoking, as well as the presence of other chronic pain conditions. So from my standpoint, when I'm seeing a patient with a facial pain complaint, the first step is always history taking, and really a detailed history is what makes or breaks the diagnosis. Ultimately, headache disorders and primary facial pain disorders are clinical diagnoses. So that means there's not a blood test or an imaging test that we do to diagnose it. It depends on the description of symptoms. So really history taking is the key. When we're evaluating pain, there's several particular kind of key points that I try to look for in a facial pain history. So certainly, when did the pain begin? Were there any triggering factors? Did they have some sort of trauma to the face, some trauma in the mouth that kind of led to this? Where do they feel the pain? Does it radiate elsewhere? And this is important when we start thinking about something like trigeminal neuralgia, and we look, you can see this figure on your screen here. You can see the different kind of distributions of the branches of the trigeminal nerve, as well as the other sensory nerves of the head and the neck. So if there's radiation outside of the distribution of the trigeminal nerve, that makes something like trigeminal neuralgia less likely. Is the pain continuous or intermittent? How long does it last when it comes? And what is the character of the pain? Is it dull and throbbing? Is it sharp? Is it electric? Is it tingling? Is it burning? So this really helps us differentiate between a classical trigeminal neuralgia versus an atypical facial pain or a trigeminal neuropathy. I like to get an idea of how the pain has progressed over time. Has it continued to be episodic? Has it been present for some time? And has it changed into more of a chronic pattern? what makes it worse or better? Are there triggers? The triggers part is important because when we talk later about trigeminal neuralgia in particular, where the presence of tactile triggers is part of the diagnostic criteria. And then finally, how does it affect your daily life? You know, for me, I think this is a really important question because I also want to make sure that I'm addressing quality of life for these patients, because this is facial pain is generally something that, you know, really innocuous things like talking and eating, things that we do without even thinking, can be really affected, and it can have an emotional and mental impact on patients as well that ultimately can affect their treatment response too. So I want to make sure that I have a good idea of how they are coping with the pain that they have. After taking a history, certainly moving on to the physical examination, the things that I like to focus on for a facial pain complaint. So, you know, a general physical examination, looking for color changes, swelling, skin lesions, any palpable lumps in the face or the neck area, and then a complete head, ear, nose, and throat, as well as a neurological examination, taking special care to look at the TMJ and the muscles of mastication, seeing if there are any trigger points, any muscle hypertrophy, and then checking facial sensation that would potentially make me concerned about secondary etiology of their facial pain as well. And then this really is just to kind of give you an idea of, from the neurologist standpoint, what I'm kind of thinking of or what's on the differential as I'm going through this history and this physical examination. So certainly trigeminal neuralgia, whether it's idiopathic or secondary, a trigeminal neuropathic pain, other cranial neuralgias, and then other kind of less common primary headache disorders like the trigeminal autonomic cephalgias. Certainly, you know, our common headache disorders like migraine and tension type headache can have radiating pain into the face as well. And then is there any kind of non-neurogenic pain condition that comes up? So these are kind of the different things that I'm thinking about, and that I'm hoping the information that I'm getting in my history and my physical exam is really helping to kind of narrow down this differential list.
And so this is an outline of the diagnostic classification for orofacial pain. The first edition came out in 2020. And this is an international effort to get people from different disciplines represented in that process of outlining the diagnostic criteria of the different diseases that present in the face. And so the common ones for the face, the most common, and that's why it's listed as one, is orofacial pain disease, so tooth disease. Myofascial pain is by far the second most common, followed by pain in the temporomandibular joint, hence the reasons of 1, 2, and 3. Then we get into, in this classification system, classifying the neuropathic pain disorders, and they can broadly be split into two different types. One is what we refer to as the neuralgias. Those are pains that come and go, so there's no pain in between, a sharp-shooting lancinating pain when it is there. There are variants of that that have different characteristics, which you have to know about. And then the second aspect are the neuropathic pains that are continuous, which we call neuropathies. And so these are pains that usually are associated with disease or injury to the trigeminal nerve, and they're chronic continuous type pains that wax and wane a little bit, but again, there are variations of that that can make it hard to distinguish and the overlapping aspect. The fifth is the presentation of headache disorders in the face, as opposed to what's thought of being more into the head, which is above the eyes and behind the ear aspect of things. And then in most classification systems, you have this last group, we call them idiopathic facial pain. Idiopathic is just a technical term for we don't know what it is. And so you can think of it as these are the ones that we see enough that we recognize that there's something there, but we don't know enough about them to be so clear in being able to put them into other groups. And so the goal of classification always is to try and make that group as small as possible, learn more about it, and when we can, put them into other appropriate groups so we can understand them better and therefore treat them better. So next slide.
So, after that kind of introduction to facial pain and how we kind of approach that evaluation and what we're thinking about, we have a few case presentations that we wanted to run through with you guys. So we'll go ahead and get started with the first one. So this is a 62-year-old woman who comes in with a face pain complaint. Her HPI, she tells you that she has a 6-month history of left-sided jaw pain. It's intermittent. The pain is severe. It's 10 out of 10 when it comes, and she describes these brief electric shock-like pains that are lasting seconds. She does not have any sensory abnormality, so there's no numbness or tingling of the face. She has triggers, so she says the pain can come on when she's washing her face, she's brushing her teeth, cold air blows on the face, or when she's chewing. In between episodes, she's pain-free, so she doesn't have any baseline pain between the sharp pains. Notably, she denies any ipsilateral autonomic symptoms, so no eye redness, no tearing, no nasal congestion. As far as her other history, she has hypertension, hyperlipidemia, diabetes, so some vascular risk factors that are relatively well managed. She's tried NSAIDs and muscle relaxers for this pain that have not been very beneficial. She even had some dental work done that did not help the pain. Her family history is pretty non-contributory, except her mother has multiple sclerosis. And her exam, her mental status, she's awake and she's oriented. Her cranial nerves are all intact. So notably, her facial sensation is intact. She does not have any facial weakness. She does not have dysarthria. Her motor exam is normal as well. So her neurologic exam is normal. So I think, really the key things to look at here, and you can see that this nice case HPI kind of goes off of the initial history taking questions that I presented earlier, but she's describing this intermittent pain that's electric and shock-like. So that electric shock-like pain is kind of a buzzword that we think about when in neurology at least, which really points towards a nerve-related pain. And if it's involving the face, then we think about trigeminal neuralgia, with the trigeminal nerve being the sensory nerve to the face. She's describing these tactile triggers. So things like washing the face or brushing the teeth or cold air blowing on the face can trigger these pain episodes. I mentioned that she doesn't have any ipsilateral autonomic features. So that's kind of a key pertinent negative in her history to rule out a trigeminal autonomic cephalgia. So there are these rare more rare primary headache disorders like cluster headache, paroxysmal hemicrania that can sometimes be misdiagnosed as trigeminal neuralgia because they involve pain in the face. But usually these will be associated with these autonomic symptoms. So this patient notably does not have this. So if you didn't figure it out by now, this is a case of trigeminal neuralgia. And here, this is the ICHD-3, which is the International Classification of Headache Disorders, which is in its 3rd edition now. This is the diagnostic criteria here for trigeminal neuralgia. So these are recurrent paroxysms of unilateral facial pain in the distribution of one or more of the divisions of the trigeminal nerve without radiation beyond. So that's that key point. So if somebody's coming in and they have radiation, they have jaw pain, but it radiates into their neck or into the back of the head, that makes something like trigeminal neuralgia less likely. The pain has the following characteristics. So it's short, it lasts from a fraction of a second to 2 minutes. It's severe in intensity, and it has this electric, shock-like, shooting, stabbing, or sharp quality. So again, that quality is important because if somebody's saying that they have dull, throbbing, aching pain, that points a bit away from trigeminal neuralgia as a diagnosis. And then finally, that last letter B in the diagnostic criteria says that it's precipitated by innocuous stimuli. So these are those tactile triggers. So again, if somebody doesn't have any tactile triggers, touching the face, talking doesn't trigger their pain at all, that makes me think that maybe there is something else going on, or trigeminal neuralgia may not be the diagnosis here. Okay. So then we'll move on to the second case. So this is a 46-year-old man who's coming in with a complaint of throat pain. So he describes a one-year history of pain that's in the back of the throat. but it's been worse in the last 3 months, which kind of prompted this evaluation. Again, this pain is intermittent. It's severe when it comes. He describes sharp and shooting pain that lasts up to 1 minute. There are no sensory abnormalities. He's pain-free between episodes, and he has some triggers here too. He says that drinking water, swallowing, or yawning can be triggers for this pain. And so again, if we look at the character of this pain, sharp shooting pain, severe pain, intermittent with pain-free between episodes, it does kind of sound like trigeminal neuralgia, like the case we talked about prior, but the distribution or the location of the pain is a bit unusual. So this is pain that's in the back of the throat. So there is a sensory nerve that is responsible for sensation to the back of the throat that can be irritated and get a neuralgia type of pain, and that is the glossopharyngeal nerve. So this is a case of glossopharyngeal neuralgia. You can see this diagram that shows the location of the glossopharyngeal nerve that's responsible for sensation to the back of the throat. The diagnostic criteria here are fairly similar when we look at compare it to the trigeminal neuralgia diagnostic criteria. Again, you can get these recurring paroxysmal attacks of unilateral pain that are in the distribution of the glossopharyngeal nerve. So that's really in the back of the throat or the back 2/3 of the tongue. The pain is very much like the character of the pain is very much like the trigeminal neuralgia type pain. So it lasts from a few seconds to 2 minutes. It's severe, electric, and shock-like, but it has a few other triggers as opposed to the touching face trigger. Swallowing tends to be a really big trigger here for these patients. Coughing, talking, or yawning. A lot of times I'll see these patients with glossopharyngeal neuralgia often get misdiagnosed because they're complaining of throat pain or pain in the back of their throat. They get treated for infections. They get treated for GERD or like a reflux type symptom, but what they're really having is this glossopharyngeal neuralgia type pain.
Yeah, I think that's really good. And can I get you to go back a slide, please?
Yeah, for sure.
What I want to point out is this, and this is a great image where it shows a branch of the glossopharyngeal nerve coming into the face. And so there is a variant of where the pain can be presenting at the angle of the jaw. And I think that's really important because that gets close to the distribution and there is overlap with the trigeminal. And so that can be difficult. Not so much of a problem from a treatment when you're using medications, but it's important to get the diagnosis correct when you're looking at neurosurgical treatments because the surgeons may be applying their treatments to the wrong branch of a nerve. And so that's always really important to think of. And in the differential diagnosis, just like Dr. Soni was talking about, one of the things that we're seeing in dentistry is such a big increase in HPV related squamous cell carcinoma of the throat, which has an aspect to it. So most dentists are pretty aware of that. And sometimes, and we saw some cases where HPV was misdiagnosed as glossopharyngeal neuralgia when it was actually related to an oral cancer. Thank you.
Yeah, that's a great point. I think especially when you point out the neurosurgical kind of aspect, I think neurosurgeons often rely on the diagnosis that's made by the clinician as well. And so if we're not making the right diagnosis, the patient may undergo an unnecessary procedure that ultimately doesn't help their pain either. So that's why kind of some of these details sometimes sound a little nitpicky, but that's why they become really important when we look at those procedural treatments. All
Very
right,
much.
so we can go on to the next case.
Yeah, and so I'm going to see if I can get rid of my annotation. How do I do that? There we go. I figured it out. And so this is the third case. And this is a patient, and she describes the pain starting 5 years ago, and it's been getting worse over time, kind of slowly. She says it's located in both front of her ears, and she uses her hands in that area. It has a dull, achy quality. It was intermittent to begin with, but now is a daily continuous aspect to the pain, and it's moderate in intensity of 5 out of 10 for the most times. And we usually rate pain on a 0 to 10 scale, and that's just a rating scale we ask patients to give an intensity about. For this lady, her pain is made worse with chewing, opening wide, as well as stress, and it's made better with rest and relaxation. And from a physical exam perspective, palpation of both the muscles of mastication, in this case, the masseter muscles, and the joints, the jaw joints, which are in front of the ears, and when you move your jaw side to side, you can feel them moving, uh, reproduce the type of pain. And so for this diagnosis, the key components are the provocation component, where it's made worse, and the patient saying, yes, that's familiar. And there's two parts to it, and people probably figured it out that this is TMD. And what I gave you is a classic presentation of TMD. And what you'll see here is on the left is for arthralgia, and on the right is the diagnosis for myalgia, the two different versions. And we in the field of orofacial pain are moving to try and harmonize our diagnostics and the process with our headache neurologists to try and get rid of some of the complexity associated with the different disciplines, and so that we're speaking the same language, using the same structure aspect of things. And when people look at the diagnostic criteria, you'll notice, just like in the last two, there's this letter E, not better accounted for by other diagnosis. And so the thinking that went into that is obviously if something else, like inflammation, disease, better represents the type of pain, you should be able to rule that out to then be able to come to the conclusion of this. So that's why it's a rule out, rule in, rule out. And Dr. Soni mentioned that really well, that you're listening for what we call pertinent positives, which move us in a direction, and pertinent negatives, which take us away from thinking of things. Or sorry, that but may take you away, but all in all, help uh, solidify your diagnosis. With that in mind, in the future, we're going to be looking at working between the International Headache Society's criteria and international classification of orofacial pain, so that when we're diagnosing a disorder in E, we're looking at it can't be better represented by another headache disorder or facial pain disorder to try and decrease those barriers. So with that in mind, you can see the criteria as they're written here. Is that it can be associated with jaw function, and that's one of the biggest things. And so that can be misconstrued when it's related to when you're moving the jaw with trigeminal pretty easily, because you're giving movement to the face. When you're touching the teeth together, that can be a provocation. The trigeminal happens, and so that makes it hard to go in between the two different disorders. Another aspect to it is the biggest mimic for TMD, such as jaw pain, joint pain, is actually a odontogenic disease. So everyone in the dental field should be ruling out it's a tooth origin. And common things being common, that's what we see the most presenting as jaw pain. And there is I'd say, a disorder in dentistry that sure mimics trigeminalgia, and that's that sharp shooting type pain. And in the dental world, that is when there's a crack in the tooth. So typically you'll have a tooth, and when you bite down, it separates it, and that will give and when you release it is the classic presentation of that sharp shooting type pain. And it fits with that light touch or provocation side that was mentioned earlier. It's in the distribution of a nerve, which is what the tooth is innervating the nerve, and it's really intense. And so that's where it's a mimic that needs to be thought of and worked out. And there's one other aspect that gets mixed up with the TMD and the toothache and trigeminalgia, and this is weird presentation of something called pre-trigeminalgia that happens for a while and then turns over to trigeminalgia. I'd like to hear Dr. Soni's point on this later, maybe. But I've been tricked a few times myself of thinking, hey, it's something else. And then the pain turns into this classical trigeminalgia where you go, oh my God, I know what that is. And so that dull, achy type pain that presents ahead of time can be a trick. And so we as diagnosticians first, we're thinking of all these different classifications and how they're at. So every time you're coming in, we're repeating these questions to see, have patients changed? Are you still fitting this pattern that we thought you're having? As we gain more information, we can start seeing, is there overlap of other things that are complicating the picture so that we can try and separate the disorders. so that we know what's going on. And so next slide, please. And so one way when I'm thinking of trigeminal neuralgia, and I borrowed this from a colleague of mine, I have actually a tabulation where I'll go through and I'll list all the different descriptors. And what you're seeing there is they're listed in the middle, different descriptors. And on the right are ones that would make me think that support trigeminal neuralgia diagnosis. And then if it's something different, it would take me away from supporting it. And you can use it almost like as a scoring. So it's the diagnostic criteria plus all these extra things that can make that diagnosis tip you to think one way or the other, because there are a number of patients that it's not easy and straightforward and clear. And so we're thinking of how this kind of sets up in the clinical presentation so that we hopefully don't make mistakes. But if we are thinking, hey, this diagnosis isn't straightforward, we'll be asking a lot of other questions and following closely to try and separate the different disorders that are most likely overlapping. And so with that, I think we move into the question and answer section of this.
Thank you
There's
both. Thank you both so much for a wonderful presentation. I'm gonna, if you see on the screen here, we do have the code for CE credit, which is the FPA CDE 2025. And there are instructions on how to access that here on the screen. And I believe Melissa will probably also add those to the chat. But now it's time to also get to our Q&A for this evening. To start off the questions, is there any difference in history taking or the physical exam from an orofacial pain perspective versus a neurological perspective, neurologist perspective?
You want to go first? Or you want me to go first?
Sure. I can go first. I guess I can speak a little bit from the neurological perspective. So especially when we think about physical exam, I'm also thinking about other neurologic conditions, especially for trigeminal neuralgia, or other kind of facial pain conditions where I'm worried about a secondary etiology. I'm looking for clues on my exam that could point to that. So we saw in that diagnostic criteria for even glossopharyngeal neuralgia or trigeminal neuralgia and the cranial neuralgias in general, these conditions don't have sensory abnormality. So if somebody has, pain in the face, but also numbness in a part of the face, and I can detect that on my physical exam, that makes me worried about, a mass lesion or some secondary etiology of pain. There are some neurologic conditions like sarcoidosis, multiple sclerosis that can cause a secondary trigeminal neuralgia. So again, things that I'm looking for on both my history as well as my physical exam. Am I detecting other neurologic abnormalities? Are patients endorsing other systemic symptoms that would point me towards maybe something else besides just the facial pain going on? So I guess those are the things that would kind of differ from the neurology standpoint.
Yeah, I concur with all those things. And I would say also as a response to that question, there I think is a lot of overlap. The big difference is our bias and our backgrounds of kind of how we get to this area. And so a way of thinking of it is maybe not talking about what the differences are, but thinking about what the individual strengths are that the disciplines have. And this is what I recommend to referring providers of like, okay, maybe I have a excellent orofacial pain and headache. When do I send to one versus the other? And actually, we within Minnesota will trade patients back and forth and say, hey, this patient would be better long-term managed by you because of these comorbidities or vice versa. So what are those comorbidities? If someone has MS or systemic disorders that are playing a role in their neuropathic pain, to me, that patient is better managed in our headache neurology aspect because they understand the underlying disease more so. If someone has comorbid TMD in that aspect that has an interplay between some of those, I think that's sometimes something more for the dentist that the orofacial pain, because so we can manage both of them together and save appointments for patients. Another example is if the distribution of the pain in the crossover has complaints associated with tooth and oral function and those type of things, the dentists are going to be better at probably the differential diagnosis aspect of how that pain is presenting for that specific individual because of where it's located. And I would say that if there are systemic type presentations or in someone who's more ill, our neurology headache specialists are going to be better adept at understanding and managing that patient more long term. I was wondering, you want to add anything to that, Dr. Sana?
No, you kind of covered it nicely. I think, yeah, really kind of taking into account some of these comorbidities, and then the different kind of strategies that can be used, the different types of, I think, treatments that we offer, for, procedural type treatments and other things that can help kind of as adjunct to perhaps their medication regimen as well.
Yeah, that's a really good point because in Minnesota, if it's neuropathic pain and it's presenting primarily intraorally, my physician colleagues will refer to us for the injection type procedures and stuff just because, well, we're dentists. We're used to sticking needles in people's mouths.
Thank you both for answering that question. And you've kind of touched on it, but I want to drill in a little more. Pardon the pun there, as we're talking about dentistry, but do you find that at different centers, kind of specialists work differently together? So, for example, you're talking about how you refer back and forth between neurosurgery, neurology, the orofacial pain dentistry. Is that similar at Cleveland Clinic, Dr. Sani? And at other centers, do you find that there are these multidisciplinary care teams?
So I think so that
Dr.
There's a,
Sani?
there's a sound issue happening here.
Can you guys hear me?
That's better.
A little bit.
Okay. I don't know what happened there. So what I was saying is that I think there are a lot of multidisciplinary care teams for a lot of different conditions, but I feel like, pain disorders kind of it tends to be less common for those. And specifically, headache and facial pain disorders, I think one thing is really, there's a shortage of neurologists that are headache specialists, or facial pain specialists. So certainly at, I think, bigger, more academic institutions, we are seeing more and more of these interdisciplinary kind of clinics or interdisciplinary groups where there's actual kind of discussion between the specialists about each patient case to decide what is kind of best for that patient. So that's kind of the approach that we take at Cleveland Clinic. So we have a really close relationship with our facial pain dentistry providers, our neurosurgeons, and our interventional pain management specialists. So there's a lot of communication back and forth to try to decide on the best procedure for a patient if a patient is a candidate for a procedure. I think sometimes where there isn't that communication, like we kind of touched on earlier, the initial diagnosis is not correct, then a person may end up getting a procedure that is not the appropriate procedure for them. Or if we know that there are a lot of different types of procedures available to treat trigeminal neuralgia. But if you see a surgeon that's only comfortable in one procedure, even though you may be a better candidate for another procedure, you're kind of not getting that full information. So, our goal is to really make sure that our patients are kind of armed with all the information, and that their doctors or providers are actually talking and communicating.
Yeah, I would agree. It's not common. The bigger academic centers, I think, do it more often, and partly it's kind of because they're physically more co-located, and so there's a lot of logistics aspects that need to be overcome. And the institution having an interest in its identity. So, in other words, if the institution says, yes, we are an institution that does this, we will put in the resources to make it happen. Those tend to be the ones that are able to manage a multidisciplinary clinic for a number of years, leveraging their reputation on that side of things.
Thank you both for answering that question. We have a few also from the audience here. There's someone who's, you touched on cluster headache when you were talking about differential diagnosis. Someone's sharing that they used to experience cluster headache earlier in their life, and now they've become older. They no longer experience cluster headache. They were just wondering if you could talk a bit more on that.
Yeah, so cluster headache is one of those primary headache disorders that can have, I guess the problems of it can change as with age. So we can see that as patients get older, we'll often see that the cluster cycles tend to space out more. So if in the past they may get cluster cycles once a year or twice a year, as they get older, these start to space out and they may be headache free or cluster cycle free for several years. So that's kind of the typical disease progression that we see.
Thank you. And then my understanding is kind of oxygen is a standard treatment for cluster headache. Could you touch on kind of what is used with treating that condition?
Yeah, so oxygen is one of the first line treatments as a rescue treatment or abortive treatment for cluster headaches. So, cluster headache tends to be a shorter lasting headache. The headache attack itself can last anywhere from 15 minutes to 120, 180 minutes. So it's not like, hours and hours long, but that pain itself can be very debilitating. So oxygen can be a really effective rescue treatment. I guess it's most effective when patients are at home because it does require, usually the way we prescribe it is the portable oxygen cylinders, and then the patients will have the non-rebreather mask. So they'll put the mask on, turn the cylinder on, and they'll breathe the oxygen for about 10 to 15 minutes, and that will generally help abort the attack.
Thank you for touching on the treatment of that. The next question is about, treating glossopharyngeal neuralgia. So how do you address the treatment of these different neuralgias, different conditions?
So I think Don kind of touched on this a little bit earlier, but when it comes to like medication treatment, it's actually pretty similar for a lot of these neuralgia. So we're using our traditional kind of neuropathic or antineurotic pain agents. Carbamazepine and oxcarbazepine are the first line treatments for glossopharyngeal neuralgia, as well as trigeminal neuralgia. Second line agents include other neuropathic pain medications like gabapentin or pregabalin. There's some evidence for some of the other anti-seizure medications like lamotrigine and lacosamide and phenytoin. So kind of a combination of those medications can be used. When it comes down to like treatment, whether if you're concerned about, is this a trigeminal neuralgia or a glossopharyngeal neuralgia, you're probably going to treat them both the same way, medication-wise. But when you move on to like procedure or you're looking about secondary causes, that's where that kind of diagnosis really comes into play.
Yeah, and I'd like to add, when you're thinking surgically, I understand from our surgical colleagues that they have more limited options to treat the glossopharyngeal nerves surgically, because the nerve where all the target is not inside bone like it is for trigeminal. So some of their approaches are not able to be performed.
Thanks for providing that additional perspective. That's helpful. There's a question about a symptom of neuralgias. Do you ever see ear ringing? So ringing in the ear as a symptom of any of the neuralgias?
I haven't observed that and made the connection that ringing in the ears and neuralgia are together.
Yeah, same. So tinnitus or ear ringing isn't really part of the diagnostic criteria for any of our neuralgias. I would say tinnitus is also one of those symptoms that tends to be fairly non-specific in terms that it can be caused by a lot of different things. It can be idiopathic. I would say in I can't really give like a percentage off the top of my head, but in patients that have occipital neuralgia, so neuralgia of the occipital nerve or cervical spine disease, sometimes we'll see kind of cervicogenic associated tinnitus that has to do a bit more of like that has to do a bit more with spine, upper cervical spine biomechanics that can lead to kind of referred tinnitus or a ringing in the ear. So it's in that context, with occipital neuralgia, you could potentially see some tinnitus.
I would also say that tinnitus is comorbid with TMD. I would say often. And so sometimes when you treat the TMD, the tinnitus gets better about 50% of the time. Sometimes when you treat the TMD and it gets better, the tinnitus doesn't get better, and that's about 50% of the time.
That's fascinating. Thank you. A follow-up question would be, you covered kind of primary headaches, but secondary causes as well. This is just my curiosity. Do you ever see it with someone having maybe an acoustic neuroma or vestibular schwannoma and that causing ringing in the ear that is causing a neuralgia?
Yeah, so a vestibular schwannoma or an acoustic neuroma generally affects the seventh and eighth cranial nerves. So you can have hearing abnormalities there. Depending on the size, if it grows, it can have mass effect on the trigeminal nerve as well, and then it can lead to facial pain symptoms too.
Thank you. What are the treatments we can try for these conditions in practice before we refer to a specialist?
Brandy, is your question from
Audience.
physician's perspective, from a primary dentist perspective? What perspective?
They don't specify, but let's start with a dentist's perspective.
And so this is what I teach when talking to dentists. So in dentistry, obviously you're trained to diagnose, and you're trained to diagnose things that you manage, but you're also trained to diagnose things that could mimic what you manage so that you can get the patient going in that direction. So obviously red flags, cancers and stuff. From a pain perspective, it is a realm of general dentistry to do orofacial pain. So some do, some don't. And the way I think of it to help people make that decision, providers, of whether to get involved in or not, is you have to be competent to manage the known outcomes and side effects of what you potentially going to do. And so for me, an injection into the Gasserian ganglion is something that I've chosen not to do. I technically can do it, but I don't, because one of the outcomes can be a CSF leak. And so the same thing goes with what I recommend to general dentists. If they're comfortable and they're trained to manage the side effects associated with some of the medical management of drugs used, then the answer is yes, that's within your purview. If you're not, then I don't think you have business getting involved in those. And so for medication management of trigeminal neuralgia, you really have to understand your CNS effects associated with medications, as well as the medical contraindications, because there are lab values and things that you have to follow to be able to manage your patients correctly.
Thank you, Dr. Nixdorf. Dr. Sawhney, would you like to add anything?
Yeah, so I think really as Don mentioned, I think providing the care that you feel comfortable with and that you've been trained to do is most appropriate. Certainly, if I'm talking to like a general neurologist or a primary care doctor, we talked about some of these diagnostic criteria. In some cases, it can be pretty straightforward if they feel comfortable making the diagnosis and starting something like carbamazepine, which is the first line treatment. I think that's a reasonable option, while keeping in mind that, hey, if I start this medication, these are the side effects I need to warn the patient about, and this is the laboratory monitoring I need to do. So that appropriate follow-up needs to be there.
Thank you. Thank you both for answering that question. You've talked about kind of the differential diagnosis, and you touched a little bit on, when somebody does have comorbid conditions. Could you talk a little more about, do you see patients that have more than one neuralgia, like glossopharyngeal and trigeminal neuralgia and that complicated? Or is it more people with TMD and neuralgias or primary headaches and neuralgias? Could you talk a little bit about that?
Sure, I'll jump in first on this. The co-presentation of multiple neuralgias across different nerves is really rare. It does happen, but it's really rare. I think we did a 10-year retrospective in Minnesota, which had over 250 patients in there, and I don't think it came up once. Um, Also, when we're saying the diagnosis, it's usually across different disciplines. And so sometimes there'll be a dental infection associated with also a neuropathic pain in that distribution, and that gets really hard. Or comorbid migraine. And so someone may have migraine and it gets mixed up because the migraine gets worse over time, and they have TMD type pain, and the two symptoms can overlap, and it makes it difficult for us as clinicians to recognize how they describe their pain and put it into our box. And so then you have to have, I think, a higher level of being able to question and tease those differences apart. And some of it's knowing what are the common comorbidities, and right now in our field, it's only the last 10 years have we really been thinking, talking, and doing research about comorbidities. And so it's not something that's really well known across all the disciplines.
Thank you. Thank you, Dr. Nixdorf. What is your treatment for, and I apologize, I'm going to mispronounce this, TMJ capsulitis? Am I saying that right?
Sure. So I'll address that question two ways. From a diagnosis perspective, some of the diagnosis we have sensitivity and specificity. We have known criteria of how well the diagnosis perform. And capsulitis is not one of them. We do sometimes use that term to describe a form of arthralgia where we think into more detail, if you will, that the joint pain is associated with inflammation of the part of the joint that's around it. If I'm seeing capsulitis, I'm thinking, is it strained? So a sprained strain. I'm thinking, is there a systemic arthritis that is associated with causing inflammation around the capsule? And am I thinking it's just super sensitive? It's not inflammation, it's more of a hypersensitivity state. And so those are going to be treated very differently. And so the symptom of pain exquisitely tender for the capsule can have multiple etiologies. So you have to go that next step.
Thank you. Thanks for answering that question. This one is interesting. What are your thoughts on dental acupuncture to treat TMD?
Um, I think it can be used. And so it's not something that has a lot of research, the dental acupuncture part of it in TMD. There are some publications out there that support it. There is more information growing on dry needling as a treatment for muscle pain, whole body, not just in the face and that kind of stuff. And so I think that can be translated into the dental acupuncture, and I hope I'm answering or making that assumption appropriately related to that question. With that in mind, it probably is a non-specific treatment effect, and so you're not looking at management of the etiology or the cause. So if you have a putative understanding of what are the steps that led to somebody having muscle-based pain, ideally you would want to go upstream and understand what those are, help address those so the downstream effect of muscle pain gets better. And so it can be used as a kind of strategy to bridge somebody to that latter part that I was just talking about. So short answer, maybe I should have started with that, is yes.
Thank you. Thank you, Dr. Nixdorf. Dr. Sani, did you want to add anything there?
Um, Don, I think Don covered it well, but I would say I many of the patients that I've referred to our facial pain specialist for TMD, she will often kind of advocate for dry needling or physical therapy as a part of the treatment plan, which I think is a great kind of adjunctive non-pharmacologic treatment for these patients.
Thank you. Thank you for adding that, Dr. Sani. There's a question that went back to cluster headaches, and they're asking if if it's related to hormones because it less as you age with menopause. I believe I understand that men actually get the condition at a higher rate than women. Could you touch on that as well as like gender differences maybe across the different neuralgias?
Sure. Sure, yeah. So I think in the beginning, our like who does facial pain affect slide kind of mentioned that there tends to be a female predominance. So in trigeminal neuralgia, that does tend to be the case where we see a female predominance. And actually in many of our headache and facial pain disorders, that'll be a similar pattern, except for cluster headache where there is a male predominance. As far as like relation to hormones, cluster headache, we don't know enough about its pathophysiology, but do know a good amount that we think that there's dysfunction in the hypothalamus, which is involved in some hormone regulation. There are some small research and some basic science type research that suggests a correlation with testosterone levels, and perhaps if that plays a role as we get older and the changes in testosterone levels, if that plays a role in how frequently these headaches occur, and there are small case theories that suggest testosterone supplementation as a treatment option for cluster headache. This is not something that's FDA approved, so I can't really provide too much detail kind of on that, but I guess the short answer is that yes, there's probably a link, but what that link is and what that means for treatment is not as clear right now.
Thank you, Dr. Sani. Dr. Nixdorf, was there anything you'd like to add on that question?
No, I'm thankful that we have an audience that's interested in learning and doing, and it was very nice being able to present with Dr. Soni, and I think you did a great job, Brandy.
Thank you so much, Dr. Nixdorf. And I will make this our last question and we'll wrap up this evening. And thank you everyone so much for being here. I'm thrilled that you have stayed throughout the entire, Q&A. We still have hundreds of participants here this evening. So might the plastic components of a mouth guard or other dental material create an issue?
Yes. So, most of the plastics have went through a process. So most of the plastics in dentistry that we use, that we give to patients, that are usually removable, have went through a biocompatibility testing. And so that doesn't guarantee, but it helps assure. When we do see patients that have a reaction to it, what we're looking for to make the correlation with the material is physical juxtapose of where the material is to the reaction. And so we would expect to see that. Most of the times where because I can remember one where it didn't fit this case, and I couldn't rule it out. So I inferred that it was a reaction to the material. I think I've seen one. But I've seen several where it wasn't the material, it was a newly delivered material and the monomer wasn't fully cured out of it. And so in the curing process of some of these materials, some of the components of it are not fully dissipated or removed. And those volatile chemicals will cause generalized type intraoral sensitivities. And so from that perspective, it's good to soak your new appliance in some of the cleaning solution for a bit, and use it as manufacturers in that aspect of things so that that isn't present when you start using it.
Thank you.
Answer your question, Brandy?
Yes, it does. Thank you so much, Dr. Nixdorf and Dr. Sani. Anything you'd like to add on that?
No, I would defer to Don for that management.
Absolutely. Well, thank you everyone who joined this evening for working together, better outcomes for patients with orofacial pain. Thank you, Dr. Nixdorf, Dr. Sawney, and everyone who attended this evening's webinar. Again, the code for CE credit is FPA CDE 2025, and you can scan the QR code. And thank you again for attending, and please join us for our next webinar and sign up for our newsletter to receive additional information. Thank you and have a wonderful evening.
Thank you.
Take care, Brandy and Melissa.
Thanks.
And I'm going to transition to get on to my flight.
Safe travels.
Bye.
Thank you
Travel
again.
safe.
All right. Thank you
Have a good
guys.
night.
Bye.
Bye.
Bye.